Hey everybody, you have Jane from Pollie here, and we have another Pollie specialist chat that we are doing today with Dr. Li Huo, who's a board-certified OBGYN, an expert on birth control, which is perfect because that is what we are talking about today. And so we'll kick it off by opening up this presentation. Let's make sure that my screen share is working here. And Dr. Huo, while I'm doing this, do you mind giving a quick intro on yourself?
Hi everyone, I'm so happy to be here to be speaking about one of my favorite topics in women's health, contraception. We're going to get started. So let me just start by saying that there are 5 main categories of contraception. First one is the barrier method, and First one is barrier methods such as the condom, and that's probably the most commonly used barrier method. There's a female condom, there's a diaphragm, there's cervical caps. Second category is emergency contraception, and these are methods that are used after an unprotected intercourse in which something needs to be done. I don't usually recommend this type of contraception if you can help it, but it's definitely available, so that's plan B. The third type of contraception is sterilization. Sterilization is a permanent form of birth control. So this is when women get their tubes tied or when males get a vasectomy. The fourth type is what I call the long-acting reversible contraception. So these are methods such as the IUD. And for the IUD, we have hormone-based and we have ones that are non-hormone. There is the implant, which is something that gets inserted underneath your skin. It's also put in, just like the IUD, by your provider or your OBGYN doctor. And these things work for as long as they're in your body, anywhere from 3 to 7 years. And once it's removed, fertility should return. Last but not least are hormonal-based contraceptives, and that's what we're here to talk about today. That's where our focus is today. And so the examples of hormone-based contraceptives are pills, the patch, and a NuvaRing. So the 2 types of hormone-based contraception, number 1 is the combination. The combination means that there is both estrogen and progesterone. And these contraception work by releasing low levels of these hormones daily. Now, estrogen and progesterone is normally naturally found in our bodies, so these pills mimic that natural hormone. And so these consistent doses of daily hormones that you're taking will then suppress or shut down our body's own ability or our own body's innate desire to produce hormones. And the hormones that we produce on our own are much higher and they fluctuate much more than these daily doses. So what happens when we take these daily low doses of hormones, we suppress our own body's natural ability to produce high levels of hormones, and then thus ovulation is prevented. So if ovulation is prevented, then pregnancy is prevented, and that's how this contraception works. Now the second category of hormone-based contraceptives are progestin-only contraceptives. And they work somewhat similar. They also inhibit, some example of progesterone-only methods are like the IUD, which I discussed earlier, the Mirena, the Kyleena, the Skyla, the implant, the Depo-Provera shot, which is given every 3 months, and something called the mini pill. So it's a pill that you take, but it's progestin only. And they work also by inhibiting ovulation about half the time. They increase the cervical mucus to inhibit sperm from penetrating the cervix and going up the uterine canal and going up to the uterine cavity. They also slow down the movement of the egg or the ovum in the fallopian tubes. And lastly, these progestin methods will thin out the endometrium. What is the endometrium? It's the lining of the inside of the uterine cavity. And that's what the zygote, a fertilized egg, will want to implant on before it develops into a fetus. And so the progestin-only pills thins out this endometrium, so the environment is not as ideal for a zygote to implant and grow. So those are the main birth control methods. And next we're going to talk about success rates and sort of the effectiveness of all of these methods. So overall, The hormonal-based contraceptives are much more effective than the barrier method. So that's all barrier method. That's the condom, female condom, male condom, cervical caps, diaphragm, spermicides. It's more effective than the withdrawal method, and it's also more effective than fertility awareness-based methods. So within the hormone-based methods, we're talking about the long-acting reversible methods such as the IUD and the implants are more effective than the self-administered methods such as the pill, the ring, and the patch. In the self-administered category, if you will, there's a failure rate. There are failure rates that are based on typical use and a rate based on perfect use. So what that means is perfect use means that contraception is used every time and used correctly every time. That's perfect use. Typical use is defined as when contraception is not used every time and sometimes it's not used correctly. So what that looks like in real life is if you forgot to take a pill, or if you took a pill 12 hours later than you should have. If it's a ring, you forgot to insert it on the day that you were supposed to insert it. You insert it 2-3 days later. You decide to stop a pack of pills right in the middle. The patch, you forgot to change it. So that's what they mean by typical use. So with perfect use though, both the long-term methods along with the self-administered methods are similar in effectiveness, 99%. However, we'll be comparing typical use because we're human. We are gonna have some mistakes. So between the ring, the patch, and the pills, whether they're combination or progestin only, they're comparable to each other. So whether you choose the ring, the pill, or the patch, they're all sort of similar between the three at 91% success rate. What does that mean exactly? That means that for 100 women who use these methods, 9 will become pregnant. That's 91% success rate, okay? Now, all the other methods, they're just not as effective, besides sterilization, of course. Depo-Provera, which is the injection that occurs every 3 months, is at 94% success rate. So it's pretty good. Male condom, there's a huge variation between about 82 to 87% success rate. And I'm guessing that depends on the user, and it depends on whether or not spermicide was used. Female condom drops down to 79%. Between the spermicide, diaphragm, cervical cap, fertility awareness, withdrawal methods, they're all in between the 70 to the high 80 range as far as success rate. Now, just to be clear, I would like you to be making contraceptive choices that are in the 90 percentile or higher success rate, okay? That's the type of contraception choices I would personally prefer you to be making. And of course, you know, abstinence is 100%. But that's a whole different other topic. And so as you may recall, I discussed earlier how combination hormone methods work in preventing pregnancy, by preventing ovulation, right? And how does it do that? It does so by suppressing our own ovaries, our own body's innate ability to produce hormones. And so how's that beneficial? Why are we suppressing our own ovaries? Is that even a good thing? So I'm glad you asked. It's actually very beneficial in treating several medical conditions and symptoms, okay? So one of which that the combined hormonal contraceptive is effective in treating, or at least in alleviating some symptoms, is PCOS. So PCOS is polycystic ovarian syndrome. So basically, at the base of it, it's a complex disorder of where the endocrine system is sort of going haywire, okay? And it's a condition in which the hormones are out of balance. These imbalances typically show up as irregular periods, a higher level of androgens that includes the hormone testosterone, and small cysts in the ovaries, okay? And PCOS can cause symptoms including excess facial and body hair, but yet thinning of the scalp hair, acne, weight gain, mood swings, and like I said, irregular periods. That's how a lot of the women get diagnosed with irregular periods. As women move into reproductive age where they would like to have children, it could be difficult to become pregnant. And if left untreated, there are certain medical problems that actually develop if PCOS goes untreated. So basically, bottom line is Left alone, our body's own endocrine system, in the case of PCOS, it's like a toddler going crazy without any boundaries or any discipline. And so having these wild fluctuating levels of hormones that are not beneficial to our bodies, okay?
Yeah.
So combined hormone contraceptives then allows us to have an even, calm level of hormones, okay? And it shuts down our own body's sort of wayward ways of producing hormones. And the estrogen in the combined hormone contraceptives actually increase the production of something called sex hormone binding globulins. You don't need to remember that. This basically helps to bind the free testosterone that's floating around in our bodies. It decreases its level. And then if you decrease the level, then you decrease its activities. So this will help ease acne. It will help to prevent any further hirsutism and scalp hair loss. Now with the hair that you've already gained, it doesn't really help in that way. In those situations, I would recommend probably laser. Most importantly, these combined hormone contraceptives will give you regular, predictable periods. So how else
can I ask one quick?
Yes.
Sorry, Dr. Fo, do you mind if I ask one quick question?
Oh, go ahead.
Awesome. So I've read a lot about how obviously building up the endometrial tissue and not getting your period can lead to stuff like cancer down the line. So could you maybe touch a little bit on how, like with PCOS, you're not getting irregular periods, so that lining is just building up, right? Inside of your uterus if you're not menstruating regularly. So that's really a health benefit of birth control, where even though it's not like a real period because it's instigated by a withdrawal bleed, or by withdrawing from the hormones, but it still is really helpful long-term to be getting that bleed, right?
Well, absolutely, because what it does is the estrogen and the progesterone, they both sort of what we call organize the endometrium, and then it thins out the endometrium, and then it allows it to be shed once that hormone is withdrawn. So no, there won't be as much buildup, because what happens is with time, with that buildup, then all of a sudden you get a big heavy bleed out of nowhere.
Right.
You know, you haven't had a period for 3 months.
You get a terrible period. Yeah.
Yeah. And then all of a sudden you're out somewhere wearing white pants and there's, you know, a big heavy period. Where does that come from?
Yeah.
Correct. So
yeah,
I feel like it helps with the quality. Yes, all the medical benefits are there, but also just quality of life. I feel like that the combined,
and not needing to deal with with that.
That you can actually live in a predictable way and not be, you know, not be worried about, well, when's my period coming? It hasn't come in 3 months. Is it going to happen today? Is it going to happen tomorrow?
Yeah.
Absolutely.
No, very good. Awesome.
Later,
Sorry.
I'll talk about some of the health benefits, and I do talk about that a little bit more.
Oh, very cool. Sorry.
So next we're going to talk about actually endometriosis. So endometriosis is a disorder in which the tissue that normally lines the inside of the uterus, which is what we were just talking about, the uterine cavity, it actually grows outside of the uterus. So with endometriosis, the endometrial-like tissue, they act like endometrial tissue would. So that means that it would thicken according to what part of cycle you're on. It will break down and will bleed with each menstrual cycle. But understand, this is not happening inside the uterine cavity. This is happening outside of the uterine cavity in your pelvis. You can't see this happening. And because the tissue has no way to exit, it becomes trapped, okay? And so with time, what happens is the surrounding tissue can become irritated and eventually scar tissue will form. Fibrous, thick bands, we call them adhesions, can form, and this can definitely lead to pelvic pain. And if endometriosis affects the ovaries, it can lead to a cyst formation called an endometrioma, okay? So what this looks like in someone who have endometriosis is that they have pain, pelvic pain, sort of quite severe menstrual cramps, severe than sort of the average person, if you will. And it happens quite often. They get pain with intercourse because all the organs, the pelvic organs, are sort of stuck in this fibrous, tough scar tissue, if you will. And sometimes they experience pain with bowel movements, defecation, and urination. And of course, they also can suffer from irregular periods. And again, that usually will bring a woman in along with the pain to their doctor to say, hey, what's going on? Now, there are several possible treatments for endometriosis. Endometriosis is a broad topic, and it's sort of outside the scope of this webinar, but I am going to discuss one form of treatment for endometriosis, and that's hormone therapy. Again, the idea is that we can control or minimize the amount of hormones, right, that are stimulating the endometrium and thus the buildup by using a hormone contraception method, the pill, the ring, the patch, the progestin-only methods. So this will result in a lighter period, a shorter menstrual period. So this also will help with all the implants. And so then we can control the disease process from getting worse, ideally. And if we use it in a continuous way, and what I mean by that is that you don't take a break to get a period, we can actually help with pains at times as well, and that's very exciting. So understand now that the hormone contraceptives will not get rid of the fibrous bands or the adhesions that already exist. So those you may have to have surgery to get rid of. So that's just something to keep in mind.
Mm-hmm.
There's a variety of progestin therapies that are also actually used in endometriosis. Like I said, the IUD, the implant, the implant, the Depo-Provera shot, and the mini pill. And it's the same way. They basically halt sort of how heavy your menstrual flow it is. And so then it helps with decreasing the growth of the endometrial tissue and the buildup. And so then that may relieve some of the endometriosis signs and symptoms.
Mm-hmm.
Another medical condition that we see hormonal contraceptives being effectively used as treatment is PMS. PMS stands for premenstrual syndrome, and it's a condition that affects a woman's emotions, their physical health, and behavior actually during certain days of the menstrual cycle. Generally, just before her menses, it affects more than 90% of menstruating women, and it usually occurs right after ovulation to about just the middle of her actual period. Now, some of these symptoms, and I'm sure most of us on this webinar can attest to one of these symptoms at least, and if you say no, you've never experienced any of this, I envy you. You are definitely the great. Some of these symptoms are abdominal bloating and pain and cramping. Absolutely. Sore breasts, you feel like your breasts are sore, they're tender to touch. Acne, that happens. Food cravings, especially for sweets. We could always use that as an excuse, I guess. Constipation, diarrhea, headaches, mood irritability, mood swings, fatigue, a little bit of anxiety and depression, and sadness and emotional outbursts. So these symptoms are thought, this is not approved, but they are thought to be due to probably the higher levels of progesterone in the latter half of our cycle. After ovulation, estrogen drops and progesterone increases. And so it is theorized that maybe that is the culprit, although this condition is a little more complex than that. We can't blame it on one thing. But once again, we tend to have success if we can control the amount of fluctuating hormones that are in our body with even low doses of hormones. And so a lot of these symptoms can actually be alleviated if we put someone on combined hormonal contraceptive as therapy. Now, ovarian cysts, that's a very popular topic. Ovarian cysts are actually a normal finding in a reproductive age woman. It's as a cysts are what we call also follicles, and they sort of shrink and enlarge depending on where you are in your cycle. But once in a while, we get a wayward one that keeps enlarging, and that actually ends up requiring surgery. So if that's the case, you should definitely be on a combined hormonal contraceptive to minimize the risk of developing these enlarged cysts that require surgery. Okay, so ovarian cysts is another condition that we can definitely treat. Acne, what I talked about before, the estrogen that's in these combination pills, in these combination methods, they increase the level of the sex hormone binding globulins, and again, binds testosterone, which helps to decrease acne activity. So now we're going to talk about some risks. Are there risks? Long-term risks, short-term risks? We're going to cover it.
Mm-hmm.
So hormonal-based contraception has not been shown to cause disease per se, okay? However, as one ages, we unfortunately do develop some medical conditions like high blood pressure, high cholesterol, cardiovascular disease, autoimmune disease, liver disease, breast cancer, stroke, all the types of cancer, uncontrolled diabetes. And at that point, you may consider probably other contraceptive methods if you're still of reproductive age. There's a lot of alternatives. But some immediate considerations, though, if you are going to go on combined hormonal contraception, the most important one I can't emphasize this not enough is smoking. Do not smoke if this is your choice of contraception. This can lead to blood clots, okay? We don't want blood clots in our legs or anywhere else in our body. And that's probably one of the biggest risks of combined contraception or blood clots. Also, anyone with a history of a blood clot, I always think of Serena Williams, who had a blood clot. She cannot be on combined birth control.
Yeah.
She was such a young, active lady, and she had got a blood clot. So anyone with an inherited clotting disorder or any medical condition that causes you just to clot more easily, you're not really a good candidate for combined hormone contraception. There's definitely other options for you.
Mm-hmm.
People who suffer from migraines with aura, you're not a good candidate for combined hormone contraception. Not just, if you just have migraines, you're still okay. It's migraines with aura that we're really concerned about. Okay, so let's go back to the blood clot, because realistically that is sort of the more common or more realistic risk for combined contraceptive users, okay? So the rate for getting a clot is about 0.3 to 1% over 10 years for a woman on the pill. It's not hugely, it's not ridiculously high, but it is 2 to 6 times greater than when you compare women who don't take the combined hormonal contraceptives at all. But I want you to understand that this is still really rare. So the rate is 4 per 10,000 for non-users versus 4 to 16 per 10,000 users, okay? So the fact of the matter is, as a woman, you're still more likely to have blood clots. Your risks are actually higher during and after pregnancy than if you were on this birth control. Sort of to put it all into perspective. Because sometimes when you hear these stats, it sounds really scary. What? 6 times more likely? You know, it sounds scary. Like, why would anyone be on it? But let's look at the numbers.
Yeah.
As far as the ring is concerned, the vaginal ring, like the Nuva ring, I do believe they have a generic form now, and it's no longer referred to as just a Nuva ring. There are alternatives out there. So compared to women who don't use birth control, those using a ring are 6.5 times more likely to have blood clots. And the chance here is just slightly higher than the pill. And they think that it's because it's the hormones from the ring is being constantly released, absorbed. Whereas the pill, when you first take it, there's a spike in the level, and then it sort of drops down. That's why a pill needs to be taken every day, because it's not in your system all the time. So that's why a pill needs to be taken. But for the ring, and actually similar rates for the patch. Same idea that there's a hormone that's consistently being released, so just slightly higher. Now, the good news is the mini pill, that's progestin only, the progestin IUDs, and also the implant, which is also progestin based, there's no increase in risk for blood clots. So that's good. It's the estrogen that's sort of the culprit in the blood clot formation. So I'm here next, I'm going to talk about some long-term risks, long-term benefits. So we touched on this briefly. There's definitely a decreased risk of endometrial cancer. Again, it's because we're shedding the lining. The lining of the endometrium becomes organized when we're on hormone contraceptives, and then we allow shedding of it. If you were just on progestin only pills, it actually thins out the endometrium automatically. And sometimes people who are on progestin only, like for example, the Mirena IUD, frequently people don't even get periods anymore because the endometrium is thinned out completely. And just so you know, in some precancerous lesions, precancerous sort of findings that are before uterine cancer, we actually treat with progesterone, some form of progesterone, high doses of progesterone, to treat that pre-cancer lesion. And so progesterone is definitely helpful. There's a decreased risk, this is observational, but it's well known that ovarian cancer, that being on birth control pills decreases your risk of ovarian cancer. Ovarian cancer is one of those cancers that to this day, there's really no effective screening recommendations, and it hasn't really been established. And so by the time ovarian cancer is discovered in a woman, it's usually in a later stage than what we would like. We would like to discover right at stage 1 if it's possible. Most of the time, by the time we discover it, they're in stage 3. And so in my opinion, I think that's a huge benefit of hormonal contraceptives. And again, I think the theory is that, again, we're controlling the hormones. The ovary is not always going in and out with huge fluctuating levels of hormones. That's the theory. It's not definitively proven, but we definitely see an observation that OCP users have a decreased risk of ovarian cancer. Some other benefits is decreased risk of anemia if you are someone who have heavy periods, because again, we're lightening the periods. We're usually we're able to shorten the days that you have bleed, and also we are able to decrease the amount of bleeding that you have with hormone-based contraception. It combats thinning bones. Again, it's the estrogen that helps us with all that. That's really not the case with Depo-Provera, so I need to be very clear about that. It combats thinning bones in the combination hormonal methods. Improves acne, we talked about that. It prevents enlarged ovarian cysts, we talked about that. And that's pretty much it, although I think that's a great list.
It is a great list, yeah.
Next, we're going to be talking about what should you ask your OBGYN, such as myself. I think that communication is really important. Don't hesitate to really bring your issue up front. Don't feel like, oh, I don't know, that's kind of embarrassing. Oh, that's a stupid question. Oh, I don't know. There's no such thing as a stupid question. As a physician, I know for me, I would want to know all your thoughts and concerns, because in any myths that I could help to dispel, I will dispel it. So I would say, be sure to discuss with your OBGYN your goals and reasons for wanting to start a hormonal contraception. Or if the doctor's the one who's recommending that you start on a method, understand why a particular method, is recommended over another. Don't be afraid to ask questions. There are many different pills, many different pills. I mean, some I can't even sort of keep up with all the different pills that are coming up on the market. But the truth is, a lot of them, they actually have very similar formulation, but they're just all different names. Either way, if one pill doesn't work for you, it doesn't mean pills don't work for you, period. It means that you need to try another pill. Now, if the issue is, I can't remember to take a pill, now that's different. Maybe we should look for something like an IUD or implant for you, or Depo-Provera.
Yeah.
Okay. Now, I would ask your provider about typical side effects. Some people get nausea when they start taking combined hormone contraceptives. That's something that would be nice to know, so you know that, oh, I'm sick. Why am I always sick? No, you're not sick. You're having some nausea from the estrogen from the pills, most likely. So if that's the case, take it at night. Don't take it during the morning. Okay, ask about a backup method. Is it needed? And if so, for how long? When to come back to follow up. Ask about when you should, seek a change in the type of pills or the type of contraceptive. At what point do you throw your hands up and say, you know what, it's time? Ask your provider that. Yeah. And this goes along with the same sort of line of thinking, is ask when you should contact them and any symptoms that would cause concern. Okay, so anytime that you're starting anything new, whether it's a pill, a vitamin, a diet, a fitness regime, anything, be in tune with your body, right? Listen to it and just be more aware. Some just common sense sort of, that doesn't seem right. I don't think I used to be that way, or I don't think I experienced that until this started. So some signs that your hormonal contraceptives may not be working for you is worsening moods. That can, right? We got on the pill so we can have better moods. So worsening moods and maybe even a little bit of depression that you didn't notice was there and your life is pretty much the same. You're not sure why that would be happening. Ask about it. Spotting between periods. Now that is a common thing that can happen when you're first starting a new pill. I would give yourself 3 months. After that, if that's still happening, I would go back to your provider, your OBGYN, and say, listen, I'm having a lot of spotting. Is there anything you can do? Usually what that is again, we're just adjusting the pill. We may need one that's a little higher in estrogen. Okay? Worsening cramps and pain. That's shouldn't be happening either. Typically, this happens if you have an IUD and somehow the positioning is not correct, it's moved or something, and so you're experiencing more cramping. So I would go back and see the doctor and see, hey, is the IUD in the right placement? Yeah. Okay. Now, what I'm about to list next are really rare sort of reactions, but it's just something that I want to put out there, and again, it's so rare. Allergic reactions are quite atypical, again, because these hormones are, even though they're formulated in the lab, they copy or mimic our own hormones. So we're not allergic to our own hormones typically. Okay, but if you have like sudden achy soreness in your leg, trouble breathing, severe pain, some very bad headache, like I said, headaches that are worse or different than what you're used to. You see an aura, any yellowing of your eyes that indicates a liver problem because our pills are metabolized through the liver. And just any sudden weird pain, nausea, sweating, trouble breathing. And those are sort of the immediate symptoms that you need to seek a healthcare provider. And I think that's about it. Do we have any questions?
Amazing. Yeah, we do have some Q&A. And before we jump into the Q&A, I would just like to thank you. That was super informative. By nature of what Pollie focuses on, we focus on hormonal imbalances. There's a lot of lifestyle-based approaches that we will post about and stuff, but we just believe so strongly in women using birth control to manage hormone imbalance symptoms, that that's the best option for them. And so we really do appreciate this perspective, and we know that the community will find this very helpful.
Good.
But with that, so I posted a question box to our Instagram yesterday, and we got some nice questions in here from the community, and so we can just switch over to Q&A. We'll start off with the first question, which is, do levels of hormones vary by birth control type? So are some birth controls higher hormones, some are lower doses of hormones?
Okay. So let me just touch on the pill first. Within the pill, there's definitely varying levels. You'll find some ones that are very low dose in estrogen and some that are higher dose in estrogen. So understand, pills have been out for a long time now. They used to start out with 100 micrograms of estrogen, ethinyl estradiol. Yeah. Now they're down to 20. Okay, so I want our listeners or our viewers to understand that what you're getting nowadays is all basically considered a low dose. The highest one on the market is about 50 micrograms, and that's very rare. And very few practitioners will actually prescribe that. So on average, most women get about 30, 35, or 20. Those are the really low ones. And then, so the estrogen doesn't really change except for the dosage in the birth control pills and the combined hormonal contraceptive pills. The androgens, the progesterone do change. There's about 3-4 types of progesterone, and those can be adjusted as well. Got it. So that's the pills. And so overall, as far as the progestin IUDs, they release low consistent doses of progestin into the body, and that's how they work. So they do not have any estrogen in them. And I would say overall, they tend to be a little lower, but they're more consistent. What I touched on basically before, the pill has small fluctuations, and that's why we need to still take a pill every day to get the blood levels of hormone versus our own big fluctuating levels of hormones. And then with the IUD, it's very level, it's consistent. And so it is lower than what I would say the birth control pill is overall. And that goes the same for any of for the injectable, for the IUDs, and for the implants. And as far as the NuvaRing and the patch is concerned, there's only one dose for those. There's no different formulas for the patch or for the ring. And what I would say again is pretty low in the sense that because it's consistent. So you're getting this like complete level of this sort of plateauing or straight level of hormones on a daily basis. So sometimes for the ring and the patch, I recommend it for women who don't want to take a pill every day, who forget to take a pill every day, but are able to remember to change the patch or take a ring out, and who don't want to experience that many up and down with the pill if they get nauseous.
Got it.
The pill, the NuvaRing and the patch is actually very well tolerated for that.
Super interesting. No, that's super helpful info to know. I did not know that. I don't think many people do know that. So it's definitely helpful stuff to be armed with when you're talking to your OBGYN. So our second question is relating more so to PCOS. And this question is, are there any pills that generally help manage PCOS symptoms better? For example, pills that are not shown to increase androgens. And this person is mostly concerned with hair loss, it looks like.
Okay. So overall, if you choose to be on a combination hormone contraception, your symptoms overall. So no matter which pill you take, it will help you. But I understand the fear. And what you want to make sure you do, especially with hair loss, you want it to stop. You don't want it to keep happening. And on the head, so you don't want hair loss. On the other parts, you don't want to grow more hair. And so so what I'm saying is taking something is better than not taking anything. And so you're still going to be better off by taking something. Now, so what you want is you want a pill that has a lower dose of progesterone. So that's something you can discuss with your doctor. Like, I want something that has a little bit higher in estrogen, but a little bit lower in progesterone. That's really what your fear is. And you could just always try it. I personally love the progesterone of desogestrel. That's the type of progesterone. I think that's a very well-tolerated progesterone. But this has not been proven. So let me just tell you, what I'm telling you has been studied. Like, no one has broken down the different progesterones and saying this one's better for PCOS, this one's the worst for PCOS. So that data currently I am not aware of. But I do know from experience that for me, the progesterone I personally favor is a pill that contains the progesterone called desogestrel. I feel like that's a very well progesterone. There's something called North syndrome, and that if you go on a lower dose, you should be fine. Levogestrel, and the Mirena IUD, again, go lower on that dose if you're concerned to start with, and just start there.
Start lower. So super interesting. And I remember I do have PCOS, and I was on a pill when I was in college that was not progestin only. It was a combination pill, but it was really, really low in estrogen. And I do remember when I was talking to my OBGYN about other options, recommended going on a higher estrogen pill. And I was a whole different story that we won't even get into, but even that, it took me a long time to get that little bit of information. So I think it's really helpful for people to understand that.
Right, so you could just rewind a little bit back to that hormone I see you didn't have to remember. Estrogen stimulates hormone binding globulin. That binds the testosterone, which is one of the androgens that PCOS tends to have in abundance.
And it helps it.
Right. Binds it so that it's not active, right? And so that's what I said. So you can't have one that's too low in estrogen. So you're playing with a balance of the two hormones. So to say this one's evil for sure, you can't really say that because every pill has a balance. So you kind of have to find that and work with someone, a physician who is willing to work with you about that and to sort of look at it and say, let's try this one. This one has 30 mics of estrogen and has, low dose. I don't know the dose of the progesterone's off the top of my head, but but those are all available to us. The dose.
Absolutely.
So you could look at that and see. And I do have to say the NuvaRing, the progesterone NuvaRing is very well tolerated as well.
Very cool. I think I have heard that also, but another good one for all of our listeners to know.
Yes.
Awesome. So we'll move on to the third question then, if you're ready. And
Yep.
this one is, how long is it recommended that women wait after starting a new hormonal contraceptive before deciding if the symptoms are not going away or not? So basically, how long do you give a new pill before you decide it might not be the pill for you,
Okay.
if you're having
Right. So this is
symptoms?
very common. Once in a while we get lucky. The first pill that we start on is the one we love and we stay with it forever.
Mm-hmm.
But sometimes we need to sort of work with that and figure it out. 3 months. I would say give yourself 3 months for your body to adjust, to see if the reasons that you're on it, for example, bloating, abdominal cramping, those types of things, whether or not it goes away. My suspicion is most pills do work in sort of decreasing menstrual flow, decreasing the days.
Mm-hmm.
But sometimes I find that it doesn't work as well for mood. Mood seems to be the one that, or spotting in between periods. That seems to be the reason that people need to adjust pills. But usually other things like the number of days of bleeding, the amount of bleeding, cramping, and soreness, it seems like most pills do address that. But it's the bleeding and the in-between periods that sort of cause people to go back to their doctors, and sometimes the mood too. Like, oh, I don't think this is helping me. How come I feel oddly more sad? You know?
Oddly sad, compared to normal. I think the mood thing is really interesting because a lot of, like the one pill that I just been mentioning, I was really down when I was on it and really anxious. And then I have a lot of friends who they are just so much more stable and so much more happy when they're on birth control. So it really is a matter of finding one that's a good fit for you, or finding a pill or whatever method that's a good fit for you.
Like I said, a ring or a patch. I remember during residency, I was on a study trial for a pill. I remember, and it was the same thing. I was oddly sad, and I'm not usually a sad person. And
right.
That pill, that progesterone, is not on the market.
Yeah, interesting. So it was making a lot of people.
Maybe enough people step forward and said, this doesn't seem right. And so that I do not, that progesterone is not on the, because I remember what that progesterone was. I was like, I am not taking anything with this progesterone ever again. And it never went. So it's interesting. Yeah, no, very, very neat stuff. So that was the end of the Q&A. But again, thank you so much. Would just really like to emphasize again how important the dialogue with the patient and OBGYN really is with this. Like myself, I was on a pill for about a year that just wasn't working for me. And it really turned me off of birth control. Whereas if I kind of hit that 3-month period, had an open dialogue with my OBGYN, I think it could have been a much better experience for me. So cannot emphasize that enough to anyone that is on hormonal birth control or thinking about hormonal birth control, that it's the #1 piece of advice that I have. Absolutely. And even, as me lecturing, and I've taken care of many patients and put many patients on contraception, if I'm not the one taking care of you, it's difficult to advise you and follow you completely. So it is very important to find a provider that you can speak with frankly, and to, sort of look at this and find a method that works, because there's a method out there for everybody. There is. Yeah, absolutely. Well, Dr. Huo, thank you so much for the time. Where can people find you on social media? And I'm sure they'll want to follow along after this conversation. So you can find me on Instagram. My handle is @glammamadoc. I currently do not have an active office practice, but I'm definitely available virtually, telehealth. So get in touch with me, and I'm happy to help in any way I can.
Awesome. Yeah, so everyone, Glam Mama Doc, and we will link to that in our YouTube notes as well as on Instagram.
Wonderful.
Awesome. Well, thank you so much, and excited to post this for everyone to see.
Yay, I am too. Have a great day. Bye, everyone.